Great. Um, it looks like you have a film set for the first Roblox movie behind you. And apparently I have a giant butterfly. So this is
Yeah.
Very cinematic and all of that, but just taking a peek here. So I guess we can just get started and people can join us. I know you're going to be busy no matter what time of day it is. So welcome to REMAP Therapeutics third webinar, everyone. And we're extremely happy and excited to welcome Dr. Joel Castellanos of the Psychedelic Health and Research Initiative at University of California, San Diego. So they're a initiative right now, and I know you guys are working towards becoming an institution, which would be just so awesome with a building like that to have it in. I mean,
yeah.
What could you expect? But just to familiarize folks a little bit with who you are and your background, would you mind just giving us a brief rundown of your current position and your training?
Sure. Yeah. So I did my medical school training at University of Toledo, and then went and did my physical medicine and rehabilitation training at University of Michigan. Following that residency training, I came to UC San Diego for a pain medicine fellowship, and I stayed on as faculty here at UC San Diego to help with not only pain medicine as pain medicine faculty, but also to help grow the rehab footprint here at UC San Diego. So I spend quite a bit of my time taking care and helping collaborate with patients who've had spinal cord injuries, strokes, brain injuries, amputees, burns, multiple sclerosis, to really try and optimize their function and improve their quality of life.
Okay, that's quite a bit. And also at some point, I believe you did a internship or a fellowship with Andrew Weil, is that correct?
Yeah, so I did that. So University of Arizona puts on a 2-year integrative medicine fellowship that I participated with. I think that, both for the rehab patient populations, as well as patients suffering from chronic pain, my goal really is to just have as many clinical tools in my toolbox to offer, each individual patient.
Yeah, and I think that bears some emphasis. There are a lot of different tools out there. Not all of them have made it through necessarily a full clinical trial, yet we do see pretty strong anecdotal reports about something working for some certain portion of a cohort, and you never know what's going to work for who. You can try everything that's standard of care, but sometimes it's like, yeah, I did this weird thing, and then suddenly like their knee stopped hurting, and so
yeah, I mean, I see that a lot in patients with chronic pain, who a lot of them come to our pain clinic and we're kind of the end of the road, and the providers who have seen them before have tried all of the things that have randomized controlled trials for, and you got to start thinking outside of the box. And that's one of the reasons why I really love the field of pain medicine, is because in order for my perspective on it is, in order for me to really be able to help people, I have to learn them, learn what their values and goals are, and then be able to learn how they interact with their pain. And that kind of gives me some insight of things that may be successful for that individual.
Right. And just to be clear, when you say, you're a doctor of physical medicine and rehabilitation, for those that don't know, the shorthand for that is physiatry, right? And this is right, not psychiatry, physiatry. And so you're a physiatrist. And you're mostly in there almost exclusively helping people that in fact are suffering from chronic pain or having to rehab from either severe injuries, diseases, conditions, the whole gamut.
Exactly.
And so it's a very direct intervention, and it's also a very broad field.
Mm-hmm. Yeah, one of my, I mean, so I did med school. I'm an MD. A lot of people confuse physical medicine and rehabilitation, or PM&R, or physiatry with PT or psychiatry. You know,
Right.
so there. But one of my mentors in residency said, there's a lot of different specialties that are really good at saving lives. PM&R or physiatry is really good at saving lifestyles. Wow. And so, it's very comprehensive, very holistic, and really focused on improving function and quality of life.
Yeah, and there was a very interesting study that recently got released that I believe was a DID analysis of SSRI's effectiveness, and rather than, and it was compared against people that were on SSRIs versus, and this was a big database scrub. It was people that were on SSRIs versus people that were not SSRIs, and the two other measures that they had was, it was mental health, but it was also quality of life, which you just mentioned, as well as physical health in addition to mental health. And they showed over time no difference, no improvements in improvements in mental health for people on SSRIs, no improvements over people not taking them in quality of life, no improvements in physical health. And it's like, wow, that's striking. That's and yeah. I mean, that was a big part of my story in terms of how I ended up finally going into enrolling in NYU's study trial for psilocybin for major depressive disorder. I went back to standard psychotropics, but I had an eye out on what I was seeing in the environment around me with other people on some of these, and I also knew this is about a 50% chance of working, which is not really much better than placebo. And I didn't necessarily want what they had. I mean, the side effects are very real, and in particular with me, I was having suicidal ideation, and no thanks. I don't want to take anything that's gonna make that feeling only compound. So anyways, shenanigans. So going along that track, what leads someone who is on the faculty teaching PM&R, right? To deciding, I think we should investigate psychedelics and how they can improve outcomes for chronic pain sufferers. Just briefly letting folks here listening know, if they don't know this already, Dr. Castellanos here was the lead author in May of 2020 of a landmark paper called Chronic Pain and Psychedelics, a Review and Proposed Mechanism of Action. Sorry, I get a little emotional around this. And this is done in concert with your team at PHRI. And really, you laid out the entire landscape. And as far as I can tell, everything that has developed since, you guys, I had to go back over this to get ready, but you guys actually kind of looked a little bit forward into the future and saw some of the research coming down the pike. And I think in this paper, there's a couple of places where you question, well, we don't quite know this yet. Well, we actually know this now, much more clearly than we did then, and in such a short time. But what led to you and your
Yeah.
team deciding like this paper needs to be written and it needs to be written now?
Yeah. So, I mean, what initially led me to go from my physical medicine and rehab residency and to pursue a pain medicine fellowship is a lot of these patient populations, whether it's someone who suffered a spinal cord injury or an amputation or a brain injury or a stroke, most of them have some pain complaint related to what's happened to them. And so in residency, I would be doing my best to take care of them comprehensively. But if there was a pain intervention that I thought that they would benefit from, I would have to refer that out to an interventional pain physician. So in the spirit of being able to incorporate as many clinical tools in my toolbox, I wanted to gain that training of how to do different interventions to help treat pain, along with manage pain comprehensively. And so when I got, I know I wanted to do that. And when I kind of got in the throes of fellowship, everyone was throwing around this term neuromodulation. In the pain space, neuromodulation means, predominantly means the use of electricity or magnetism to alter the way neurons fire. One of the more common procedures that we do are peripheral nerve stimulation, spinal cord stimulation. We also do a little bit of transcutaneous, transcranial magnetic stimulation.
Right.
And all of these things are attempts to modulate the nervous system to help improve pain control. And so it just, with everyone talking about, throwing this word of neuromodulation and how powerful it can be and how it can change lives, it was crazy to me that no one had really, entertained the idea of looking at these, in terms of psilocybin, naturally occurring compounds that profoundly modulate the nervous system.
Yeah.
And so that's where my interest really kind of was born out of. And thinking that if we can harness this ability to profoundly modulate the nervous system and delineate the mechanism, then it may open up a whole new way to help people. And one of the reasons I chose UC San Diego as where I wanted to train in my pain medicine fellowship was because they had done extensive research on cannabis and, in relation with pain. And I knew that they were, there's a lot of really forward-thinking physician scientists within the Department of Pain Medicine at UC San Diego. And I felt, I felt so comfortable having, expressing my thoughts about, what I thought about the potential use of psychedelics with my program director and mentor and collaborator, Tim Furnish, that he was like, what, it's crazy that you say that, because just last year, we were able to help kind of resolve Albert Lynn's phantom limb pain through combination of mirror therapy and psilocybin in basically one session. And so that kind of serendipity, whatever you want to call it, that combination of what Tim Furnish experienced with Albert Lynn and V.S. Ramchandran, along with my kind of, curiosity of why haven't we looked at this yet in terms of neuromodulation, brought us to, first it was just my fellowship presentation to our faculty about the potential use of psychedelics in chronic pain. And, several of the more experienced faculty who have, experienced the opioid epidemic were like, whoa, I don't, to a lay person, it kind of sounds crazy that a pain physician would be like, I know we screwed up on the opioid thing, but let's try psychedelics.
And that's often the first, objection I hear, frankly, when I bring this idea up, and maybe we should just use this moment to really lay out to people one of the effects and you can go into this further here, right? But one of the effects that's less well known about psychedelics, but is absolutely validated, is it does not have a reinforcement mechanism the way opioids or cocaine or other narcotics do. Their effectiveness, each time you take them, if you take them daily, like say LSD, for example, by the 4th, 5th day,
it's not reinforcing.
Working. Say again?
Yeah, it's not reinforcing.
Yeah, it's not.
It's not a reinforcing substance.
No, and additionally, if anything, and Stephen Ross, who is the primary investigator for my study, who has a background in addictive medicine, right? Addiction medicine, I should say. It's if anything, psychedelics have a quality of being anti-addictive, right? I mean, we're seeing that work with the funding from the NIH for smoking cessation, helping people with 20-year pack-a-day habits that have been treatment resistant, having 6 months of compliance after 2 or 3 psilocybin sessions. That's just profoundly huge. 80% compliance is just, no one would have believed that if you had said that before. Or like, if we're talking about ibogaine and heroin,
I mean, I think that there are some really, ibogaine has its own, cardiac risk profile, but there are some really interesting anecdotal accounts of, people's experience on that in regards to addiction.
So they threw this up kind of like, hey, whoa, the opioid epidemic, I know we're all in reaction, but really psychedelics? So then what happened?
Yeah, so I mean, they challenged me and forced me to kind of take a deeper dive into the safety profile of it. I basically took the outline of my presentation and made that, the outline for the paper. Through my preparation for that presentation, I figured out that we had 2, real gems at UC San Diego, and Mark Geyer and Adam Halberstadt. Also was able to connect with Fadil Zidan, who's a great mindfulness and functional imaging researcher. And we were able to kind of come together and say, hey, this is something that we're interested in. We think that this has legs to it. And we want to be able to answer the question. We want to be able to reproduce the studies the case series that, happened in the 60s and 70s, specifically with phantom limb pain, but for other neuropathic conditions as well.
Wow. So let's talk about phantom limb pain a little bit here. And I can also kind of relate to how I got here with pain and everything as well. But for people that don't understand, right? So a lot of people have heard of phantom limb sensation, but they have not necessarily heard of phantom limb pain. And very, very frequently, anytime you're talking about phantom limb sensation or limb loss, and that includes people that have lost limbs, not only to say car accidents or industrial accidents or war, but that's also people that are say cancer survivors, diabetes, digit and limb loss. We're also talking, I think I said cancer, strokes. So the limb can be intact, but the neural connections are gone. Can you explain what is happening there that's causing pain?
Yeah, so, I think there is definitely a distinction between, there's several phenomena that happen when, after an amputation. Some people get the experience of what's called telescoping, where they feel like their limb or their hand, if it was an upper extremity amputation, their arm length is shortening. So as their kind of phantom limb pain is resolving, and it's close to being resolved, they'll feel like basically their arm is, or their hand is attached right at their shoulder, or wherever their, residual limb is. That's one thing that happens. Patients sometimes just have phantom limb sensation where they feel like their limb is still there. They feel like it might be contorted in a specific position. And sometimes they feel like they can move it around and scratch it. And, but, sometimes, even that phantom limb sensation can be irritable. Sometimes they can have intense pruritus where it's just really itchy and it can drive people crazy. And other times it is worse, and it is completely debilitating pain, lightning bolts, sharp shooting, feels like you're constantly being burned by 1,000-degree water. And so, it gets so bad for people that, life is not worth living. It can be completely debilitating and take over, someone's whole life. And, the way I've always looked at it is like, there's a clear dissonance between, what the brain is, the representation for that limb, and a lack of input. And so when the brain senses that lack of input, kind of immediately, it wants to trigger an alarm system to the consciousness to say, hey, something is not right here. We're not getting feedback from this area. We want you to investigate. And so, there are different techniques to kind of bring the actual self into reality with the ideal self. And that's like through things like mirror therapy, where we're able to kind of slowly convince the brain that things are okay, that there's not an imminent, immediate danger. And so that's kind of the way I kind of look at it. And there are different medications that we commonly use. A lot of the neuropathic pain medications can help some, but like it really is one of those. Say that again.
So, sorry, things like gabapentin.
Yeah, like gabapentin, nortriptyline or Pamelor, Cymbalta, but also, mindfulness, motor imagery, along with the mirror box therapy, are the things that, we know to help. Some of the interventional techniques that we do that have some evidence are things like dorsal root ganglion stimulation, or DRG, as well as spinal cord stimulation.
So if we're talking about that loss of signal coming up from the limbs, those afferent nerve signals, so when it's lost, that's called deafferentation, right? So if we just go back to that example of like persistent itching, right? I think it's worth people understanding. It's like, if you have this invisible arm that's there, but you can do no intervention on it, as you already described, that signal is just continuing to, it's getting reinforced, and it's not being interrupted. And in some ways it's magnifying and amplifying, because your nervous system is now doing, almost in a way, associative learning with that. That signal's not being countered. There's no way to interrupt it with something that's relieving. And you mentioned like the odd phantom limb positions, which also feels weird and disorienting. Can we, what just happened? Sorry, but it went on screensaver for some reason. Okay. Not trying to create any kind of triggering stuff here, but when you mentioned the 1,000-degree temperature or constantly burning on fire, like very early on in my career, I was working with an Iraq vet who came back, survived like a IED attack and small arms fire in his platoon, severe survivor's guilt, but also turns out he had CRPS, right? And his limb looked whole. It functioned like a normal limb and everything. There was just a small wound that you would barely notice. But eventually, and he was on opioids and they just made him miserable and they were ineffective. But his limb felt like it was on fire 24/7, right? And eventually, in an effort to, this is 15 years ago, but in an effort to escape the nonstop pain, he had the leg amputated, just out of a desperate attempt, fully functioning leg.
It's not an uncommon story in patients with complex regional pain syndrome. Obviously, we really try to do everything that we can to prevent that, and it's sad because sometimes even after the amputation, they have that deafferentiation pain and, phantom limb pain, and it opens up a whole door of new type of issues. And it can really be a huge hit on someone's psyche when they go to such drastic measures to get rid of a pain, only to be met with maybe even worse pain.
Exactly. So I mean, and that's the thing, because there's no guarantee removing that limb is not going to just create more deafferentation, right? I mean, because now there's no nerves to modulate. I mean, there's some thinking that you remove the nociceptive inputs, and so it's going to go away. But then there's also no other inputs that are countering that. And I mean, like you said, some people end up being suicidal because of this. It's like it's hard to convey to people that don't know this about chronic pain. And if anyone is listening right now that has it, my heart goes out to you. I was like a severe low back pain sufferer for 3.5 years, and I thought my whole career was completely gone and over, and nothing was working. Like everything worked, but nothing lasted. But there's a real issue with demoralization that can happen for people in chronic pain, and like phantom limb pain can just be also very bizarre, like phantom railroad spikes, or phantom razor blades, or like very odd sensations. So, hi, William. Sorry to see that about the low back pain. Maybe we can just address this since he's got it up there. We are going to follow this with a Q&A, just so you know. We'll get to that. And my pain was in my SI joint too. So we'll get to that, I promise. So let's talk about Albert Lin briefly, as far as what happened to him, and then what happened there at UCSD, and then kind of where that's opening things. I think a lot of people maybe haven't heard of mirror box therapy or mirror visual feedback, and maybe are unaware of, in terms of neuromodulation, what a profound impact and influence the visual system has on just about everything else within the neural hierarchy. You want to?
I mean, it's pretty interesting to see when I would kind of observe it and participate in it during residency training. Patients, we would set up this mirror, so it would look like they would look at the mirror, and it would look like they would have two limbs, but it would just be a mirror image of their intact limb.
Right.
And crazy enough, I remember one specific instance, a patient had really bothersome phantom limb sensation in the form of itching, and every time they would do when it would get bad, they would set up the mirror, and someone would scratch his intact limb, but he would be looking at the phantom, the mirror
image, right?
And it would help. He would feel it would help that pain or that sensation. And so, it's really interesting, and it for a lot of patients it does help, And I think Albert Lynn was one of these patients where it helped while he was doing it,
Right.
but then it wasn't always sustained. And so he talks about this in a Nat Geo talk, where, you know, when he combined that with psilocybin, kind of in line with, you know, the Rebus model or whatever
Right.
you want to call it, he was able to kind of create a new story for himself. And it gave him sustained, long-lasting relief. And you know, when we were in the infancy of PHRI, when we were talking about, okay, like, what are we going to look at? What condition do we think, you know, has the most evidence to look at with psilocybin? I mean, it was a pretty clear choice that phantom limb pain, because of, you know, what we've seen personally, all on top of the evidence back from the 60s and 70s, that was a clear, and because it's predominantly a central neuropathic pain state, that's what we wanted to look at. There was a lot of back and forth on whether we, in this initial study, we look at it with mirror box therapy or not. And we decided, you know, first study, we need to see if there's signal. We need to see if we can recreate what was done in the past, just with psilocybin on its own.
So let's break out a couple of things you said real quickly. So central neuropathic pain state. So that means that this pain is originating in the central nervous system. People have this idea, and
Correct.
There's an argument between some people and, say, Professor Thacker online about, you know, I mean, what we've always said here in REMAP's online course is that people think that pain is a sensation that is an input from the limbs and the torso, but in fact, pain is an output of the central nervous system that is a perception. And that doesn't mean there's not damage or activity around receptors out in the periphery, in the peripheral nervous system, but it is interpreted by the brain. And in fact, so there's this recent paper by Greg Corder at UPenn, where it's showing that the amygdala is actually emotionally encoding the valence of that nociceptive input, and then it goes out whether or not it passes pain or not. In fact, you talk about this in your paper about thermal and mechanical changes creating pain, or whether or not, and 5-HT2A receptors role in altering that. And for those of you that don't know, 5-HT2A is a serotonin receptor. 5-HT2A is specifically the one that's most implicated in creating psychedelic effects. And then you just also said about, so if we're talking about neuropathic, also meaning this is happening in the nerves, right? There's a problem in the nerves, but your paper also addresses that because of all those receptors. Maybe I should let you talk about this, but this is one I specifically wanted to ask about. There's something called, in pain regulation in the human body, right? We have ascending pathways,
descending inhibition,
and descending inhibition, and 5-HT2A.
So there was in you know, through the research and putting together this paper, there was a really interesting animal model that looked at how each of those serotonergic receptors changed after there was a nerve injury. And in fact, only when the serotonin 2A receptor was activated compared to the other serotonin receptors, only the 2A receptor continued to promote descending inhibition after nerve injury, where in a healthy nervous system, activation of all of the serotonin receptors help to modulate and promote that descending inhibition. So that was another thing, you know, in preparing this paper, there were a couple things that really made me think, wow, there may be something really to this. It was that study that really kind of looked at, serotonin 2A as something that has the ability to still modulate that descending inhibition after nerve injury. And that didn't occur in serotonin 2A receptor knockout mice. So mice that did not have the receptor to begin with. And then really the 1964 Castellano study that compared LSD to Dilaudid and Demerol, two very strong opioid medications, where these patient populations were hospitalized for severe pain. So these are cancer pain, ischemic pain, burns, and so they compared
shingles too, right?
LSD.
Shingles, and I think in that study, shingles and also gangrene, maybe.
Mm-hmm. Yeah. And so these are patients who have a lot of pain, and so after 3 hours, LSD outperformed both of those medications, those strong opioid medications, and at 19 hours, 49% of the patients were pain-free. And sure, there was a ton of critiques with this paper that was done almost 60 years ago, but it makes me real. It's like, hey, we got to do this. We got to at least kind of see if this signal of what they were talking about 60 years ago is true and holds up today.
Yeah, well, and some of that allodynia effects, countering pain, like were persistent even 3 weeks later, right? And I hear the criticisms. So like Professor Jan Ramekers and I talked about this when we did a webinar a few weeks back, which is that there really wasn't informed consent for most of those people. But that also means set and setting, like, on their first, they push their button saying, hey, I'm in pain. They get Dilaudid, 3 hours, that wears off. Then they push the button again, hey, I'm in pain. Then they get their Demerol that wears off after 3 hours, right? Then they push the button again, and it's like, here, try this. And they don't say, this is LSD, and it's going to magnify everything you're feeling right now about being in this cancer ward. And some of you are dying, some of you are like facing your mortality. So it's like, then they say, yeah, it's like, was it 50% of them didn't want to take it again? It's like, yeah, you didn't have adequate support, but at the same time, most of these people are also suddenly talking about how beautiful the trees outside the window are, the wonder of life, and the fact that, yeah, I know I'm dying, but I'm not scared anymore. I mean, that's a profound change in viewpoint, right?
Yeah.
I just, not having adequate container set or setting, those are forms of interventions and neuromodulation. We see the same thing in clinical trials for depression, PTSD. All of them have very strict protocols because it's always psychedelic assisted psychotherapy. That is a hybrid approach. With Albert Lin, if you don't mind, I'll just so in my background, I've been working with chronic pain and rehab clients for the last 15 years, gone through numerous advanced certifications about applied neurophysiology through one of my main organizations that I belong to. So it was around 2015, 2016 that at one of these conferences, I first heard that they were using psilocybin to treat cluster headaches. And like, we had people coming to us for cluster headaches. A lot of folks, like you said, they end up at the clinic out of desperation. They've tried everything else and nothing is working. And like cluster headaches, one of the most severe, like we've talked to Bob Wold, who's an executive director and a sufferer himself at Cluster Busters. They had the first modern studies on psychedelics and treating pain. And it's like, this is a headache so bad, people literally try to bash their heads into unconsciousness against the floor and stuff, you know, sucking down as much high dose oxygen as they can get. And you know, he says that the rate of suicide is 20 times higher, you know, 20 times higher than average. And psychedelics, and specifically mushrooms and LSD, cut it like almost, you know, instantly. Like it'll interrupt an acute episode, it'll stop a cluster or a series of headaches from happening. But so I was aware of that in 2015, 2016. Prior to that, I had heard about mirror box therapy, and V.S. Ramachandran had some great TED Talks, you know, and it's like, for people that just don't get it, it's like you stick the residual limb or the stump under an angled mirror, you look at that reflected image, and your visual system uses that as input that is missing, or that deafferentation we were talking about earlier, in the somatosensory strip in the cortex, you know, and so that itch you couldn't scratch anymore. Oh, I see it, I can see it happening, and that is enough. That is enough to start making cortical reorganization, changes, you know, which you talked about with that Rebus model. By the way, Manesh Grin, they just released a paper today doing very intensive, I guess, fMRI and pattern studies that is like more or less validating, at least he's claiming, validating major portions of the Rebus model. So that's fascinating to see. We'll see what comes out of it.
I mean, that's one thing that I'm really excited about for our study is with phantom limb pain and psilocybin, is that we're going to be doing pre and post functional MRI.
Beautiful.
So I think it's going to be really, really interesting to see what type of changes we observe.
Are you going to have, is that resting state, or are you going to have them doing some specific task during resting state as a control?
Resting state.
Resting state. Okay. Manoj Das, Dr. Manoj Das from Hopkins had some pointed criticisms about that. That's interesting to think about. Like fMRI studies are not easy to conduct, are they?
Yeah, I will preface by saying Fadil Zidan is the functional imaging expert, so he has developed the protocols on that.
Great.
I'm following his lead on the
let me see here. So have I gotten far afield? Okay, so anyways, when I went through the psilocybin study at NYU for depression, right, I was hoping I would get some relief, right? And I was aware of the Lee paper from 2018 about dendritic arborization, synaptogenesis, neurogenesis, all of that, dendritic complexity being boosted back up in the prefrontal cortex. And so that was my first ray of hope. But honestly, I just like, okay, I need to feel better than this. And I knew I was getting bad, but it wasn't until they started doing the MADRS assessments on me, which is a depression assessment. I had no idea how bad I really was till I started doing that. And then it's like, oh God, I'm pretty, you know, effed here. And I'd been trying everything I knew, like literally everything. What I wasn't telling everybody is also dealing with chronic pain. You know, just like ongoing osteo stuff, you know, ongoing somatic stuff, constant inflammation, which is often bidirectional with depression. But, you know, and my secret shame was, you know, I can do this for other people, but it's not working on me. And spontaneously during my session, a lot of issues in my right leg started resolving, like mid-session, with like very intensive tremoring and stuff like that. They freaked out a little bit, and I had to explain, you know, just before I went in my peak, no, this is like, this feels good. This feels like when someone's using one of those electro myostimulatory units, like a TENS unit, right? Things are cool. I mean, I talked about this with Dr. Ross. I went and visited him for the first time in 2 years, a week or two ago, just to let him know, like, hey, like, this is what I've been doing, like all this pain research and stuff. And like, I thought they knew, they didn't, but but the next day, like literally the next day, it's like, you know, great big download from the sky. Why doesn't someone do this like psilocybin with nearly any other neuromodulation, including the mirror box therapy, right? I had done a blog post about it.
Yeah.
And then I thought I had this great secret, right? But I'm trying to convince everyone at NYU, this is going to change the face of chronic pain. I promise you, it's going to be a completely different field in 5 years. And they're like, I thought you were an actor, you know? And so, and it's like, never through the front door. And so, and then NYC went into lockdown 10 days later. I'm inside with my 2 young boys because they're telelearning. My entire field disappears in an instant as every single gym and rehab space closes. And I'm left alone to do nothing but search online. And very rapidly, I found the, I think within 2 weeks or something like that, I found on the MAPS database under bibliography, a photocopy of the original English abstract from the Kurumaro study in Japan from 1962, which you guys cite in your paper. And it's a pilot study, 8 phantom limb pain survivors or sufferers who were given 50 micrograms of LSD, and 50% of them are in full remission by the end of the first session, right? And everyone has a clinical response, right? And they strongly suspect it's a problem with the body schema, right? Homuncular representations having maladaptive outputs due to deafferentation. They strongly suspect movement resolves both the sensation as well as the pain. So that's like, please someone do physiotherapy with these people, right? And obviously something like graded motor imagery would have been, or, Miravac. So I'm thinking, wow, I think I've unlocked the universe here. And then no joke, just as the study is ending, like literally it's like within days of me about to have my last session there, your paper came out. And here I go. Buried inside is the 2018 case study of Albert Lin using high dose psilocybin with mirror box therapy. And I'm like, this is too much of a coincidence for this. It's like, of course someone else came up with this, because we've seen the desperation. People with chronic pain, they will try literally anything just to get out of that, right? And
I mean, and I think it's really interesting. We're talking about patients who have suffered an amputee and have phantom limb pain, and how the classic sense, in pain medicine, we've used different types of electrical neuromodulation to some success. We strongly believe that psychedelic neuromodulation is going to be effective. To what extent, we don't know yet, but we think that it's going to be effective, or else we wouldn't be doing the study. And then how psychedelics open up the nervous system to be able to be plastic, to allow I read this really interesting pain psychology paper last week. It's from 1992, but it talks about pain as something that interrupts. It interrupts us. It's a survival mechanism. When we experience something painful, it interrupts our attention and diverts our attention to exactly what that pain is. Because if we didn't and we ignored threats, we probably wouldn't exist as a species. It's a survival mechanism. When those interruptions become very frequent, just like if we had a bunch of interruptions during this conversation, it would start to interfere with the ability of us to function in this conversation. And when when there are constant interruptions of pain, people's function starts to dissipate and decrease and decline. And then when those interruptions and that interference occurs over time, if we got on 10 Zoom calls and every time we got on a Zoom call together, we were interfered with and it was interfering with the function of our ability to communicate, then we would kind of just incorporate that with our identity. Like, we just know that every time that we communicate, there's going to be interference.
Yeah.
And in the same way, patients who, are experiencing those interruptions that are leading to interference with function over and over and over again, it becomes part of their identity.
Yeah.
And in that, I think that's where psychedelic neuromodulation has such an amazing potential to hit all three of those things. Not only do we think it works directly on the serotonin 2A receptors to continue to promote descending inhibition and decrease those interruptions and that interference with function, but it allows people to kind of, take a different look at their own reality and their own identity. And so I think that the different layers that we think that psychedelics may be working aligns really well with chronic pain.
So just to briefly hit on all the mechanisms you discussed in your paper, and then I also want to hit just kind of a very brief outline of your study that's coming here, because I want people to know about it and talk about it. And then we can do this Q&A if you can bear the time.
Sure.
So there are other studies out there right now that are starting to happen around psychedelics and chronic pain, but usually they're talking about a change in people's sense of agency and relationship to their pain. Like, they're talking about a positive reframing, right? And that also, because of this demoralization and this shifting identity, like this very severe shifting identity of a person with agency over their thoughts, their cognition, right? So people have to understand chronic pain is not like regular pain at all. This becomes a priority of the highest urgency and order within their headspace when that pain is going on. And if it can't be relieved, it's just, it's literally like a hurricane coming through.
It's debilitating. It's completely debilitating.
Yeah. And it's like, and like, let's just sidetrack. Like, if you're talking about people going through therapy for cancer or something like that, a lot of that works durationally by repeated exposure to chemo or something. But if you're in constant nonstop pain, people's resolve to deal with that can really be gutted, right? So back on track. So we're talking about, there's the cortical reorganization where, people with depression, they're having something called iterative rumination. It's a looping negative thought or framework around their self, their life, expectations, right? So, and it is a maladaptive output of the cortex. And in the same way, though, we can look at chronic pain as also being that. So we're talking, that's where the Rebus model comes in. So that's one change that we see happening, right? Then we have descending inhibition. So that's like actually the nervous system inhibiting pain signals, right? Down, and when you mentioned DRG, dorsal root ganglia, so that's down at the level of the spine. So even before that signal gets up the spine, where those nerves are decussating, we're seeing that getting inhibited right there. So it doesn't even rise to the level, or not nearly with as strong a signal, up to the central cortex. Then we're also talking about two others that we don't talk about too much, but there's anti-inflammatory properties. So literally, we're if we're talking about CRPS,
The evidence for anti-inflammation is through the TNF alpha, which is an inflammatory mediator. It blocks that inflammatory mediator. That's what the majority of the body of literature shows.
And TNF is tumor necrotizing
necrosis factor.
Necrosis factor.
Yeah.
Yeah. So so that's also happening. So the inflammation is being lowered. I'm going to talk about both of these things personally in a second. And then there's also a change in gene expression. So immunomodulatory. So literally there is enough neural change from the psychedelic intervention that it is changing how your genes are expressing responses in reaction to the condition you're currently under. Correct?
Yeah. So, I mean, it upregulates genes that are associated with learning and neuroplasticity.
Wow. So, I kick myself for not having remembered to bring this up with Jan. So Jan, Professor Ramakers, did the most recent study in recent memory after nearly 50 years on LSD and pain inhibition. And it was with healthy normals, people that aren't in pain currently, but they took a very low dose, not a microdose, but a low dose, 20 micrograms. And then they take a standard assessment for pain tolerance called a cold pressor test. You submerge your hand in icy water and you leave it in as long as you can. And it's like, how much does this hurt? How bad do you feel about yourself? How much do you hate me? So, and then like eventually, you record that time and you also do a scale. So from my Aikido background, I had been doing tons and tons of cold water work and I'd let that lapse. But as the depression was kicking back in, I started doing cold water training at home again. And I used to be able to go into icy rivers, icy lakes, no problem, right? Did it every morning, dousing the whole 9 yards. Now we see Wim Hof and those people kind of bringing this all back. And there's supposed to be some immunomodulatory effects. But anyways, I was doing it as this kind of willpower building thing. As the depression was getting worse and worse, it was becoming painful. I could no longer tolerate it the way I used to. My scalp, the musculature up there was literally contracting, and it only seemed to make the depression kind of worse in a way. Post dosing, I kid you not, I could stand in there for 5 minutes and it felt like it was happening to someone else. And eventually I had to get out because I was bored. I went on to the New York City Water Department database. I did a search for, does the temperature of the water in New York City fluctuate? March is the coldest month because of, I guess, the beginning of the snow melt off. So that is there. And then in terms of this anti-inflammation, my total inflammatory level in my whole body rapidly went down. And like osteoarthritis pain I had in my big toe, zapped it. And I'd gotten that assessed 3 months prior. So anyways, would you mind telling folks, just we've alluded to it, but let's be very specific. You guys are doing this brand new psilocybin and phantom limb pain study. Can you tell us how many people are in it, what you guys are going to be doing? You mentioned also fMRI.
Yeah, so we're gonna, the goal is to enroll between 25 and 30 subjects who suffer from phantom limb pain. We'll be doing baseline functional imaging before, and then two functional imaging sessions afterwards, both kind of immediately after, within a week, and then after a couple months, to see what kind of changes there are. But yeah, I mean, I as we were getting prepared for this study, even when we're thinking about the patient cohort of patients who have sometimes have disability, sometimes have difficulty transferring, difficulty with mobility. We had to really make sure that the people who are going to be sitting with these patients have adequate training in how to assist patients when they're not in a psychedelic session, but also when they are. But yeah, I think, we're all really excited about enrolling, which is currently underway, and moving forward and kind of getting through the data and hopefully helping people most importantly.
Well, if people go to both the PHRI Twitter account or REMAP Therapeutics Twitter account, we have the graphic up there. It's got a QR code on it. There's also a website, there's phone numbers. If you know anybody out there who's suffering from phantom limb pain, is that only for limb loss or is that all types of phantom limb pain?
Yeah, limb loss.
Okay.
Specifically limb loss pain, yeah.
So if anyone knows somebody that maybe is dealing with chronic phantom limb pain, please refer them to PHRI here. So how about with the time remaining? Well, we've gone an hour. Can you spare a couple more minutes so we can just talk to folks here? So I'll go to the Q&A part first, then we'll go William Blake. Well, actually, let's go to William first since he did have the first question. Oh, it's up here too. So can you briefly explain the application of SCS? I am curious as a potential
spinal cord stimulation.
Spinal cord stimulation, hopefully, as a remedy for my chronic low back pain and post-septic arthritis in my sacroiliac SI joints. Oh, they're tricky. Thank you. And why don't, let me just see attendees. William, if you would like to talk, you can. If you have any more direct question, if you want to ask it directly or.
Yeah, if not, I can kind of touch on that. So
go for it.
In regards to spinal cord stimulation, the most common indications that right now that we use it for are for people who have had back surgery and continue to have back pain after their back surgery, chronic lumbar and cervical radiculopathy. So, pain that starts in the neck or starts in the low back and shoots down the arm or leg respectively. There are a couple companies that just got FDA approval for painful diabetic neuropathy, which is a new indication. And so I have not seen spinal cord stimulation used specifically for sacroiliac dysfunction. I think that, the nice thing about spinal cord stimulation is you can do a trial. So you can place the electrodes without having to do the big surgery and see if it's something that is going to benefit. But there are other types of neuromodulatory, approaches for SI joint. We can inject different things into the joint directly, whether that be corticosteroid, regenerative therapies like stem cells or platelet-rich plasma, and then there are radio frequency procedures and nerve blocks that we can try to help kind of decrease that painful input from the joint. Wow.
So I had 3.5 years of SI joint pain. I couldn't get out of bed in the morning. I would walk, I'd sneeze and my hips would buckle, squatting, everything that I used to do like flawlessly, really, really messed up. And then I saw someone do a variation on a long adductor stretch, but they externally rotated their hip. And I'm like, oh, that looks like, a little bit like some of the tibial and peroneal nerve glides I've seen. And then I went to town with it. And I'm telling you, 48 hours later, there's still a video of this on my old website, courtwing.com. And you can just look in my blog. It's one of the only blog posts I made, but it's like, look at this. Did I invent this new stretch? No. Look at all these other people that have done it before. But just change the neurodynamics on it. But so I've met so many people that have had to deal with that SI joint pain, and like there's no, it doesn't seem to have any common etiology as well, which is the
No, I mean, we see it a lot in women who, after childbirth, that's probably the most frequently kind of like, textbook, but it happens a lot. I don't think it takes much, I mean, obviously when a joint gets infected, that's kind of a different level of pathophysiology. But for some patients, it's just like, they move a certain way and that sliding joint kind of gets a little bit out of place and really irritates the whole joint surface.
Yeah. Okay. Well, hopefully that's of use to you, William. Let's see. We have, let's see. What about the dosing and protocol of psilocybin in the NYU trial? Well, okay. So it was a single dose study, 25 milligrams per 70 kilograms of body weight, right? So I received a single capsule that was sponsored by the Usona Institute, and they're an open science nonprofit foundation, and they've actually published how they're making their GMP kilogram scale level psilocybin. But I had to do 2 months of assessments to see what my depression level was and if I qualified, and that there were no other exclusionary criteria like high blood pressure or cardiac history, or if I had a first relative with, say, a psychotic or manic depressive disorder. And then we did a few preparation sessions of about an hour and a half each. And then finally my dosing day came, and took it at 9 in the morning, started to feel it within a half hour. And within 3 hours, I was in the peak. And within 6 hours, actually by, I'd say around 2 p.m., I was coming down and mostly done, almost back to sober. And at the end of the day, before I left the session at 4 o'clock or so, I was in total remission, which was just completely bonkers at the time. So, and that's not an unusual report, right? Some people only have a clinical response 50% better, but it seems through most of these studies, somewhere around 25 to 33%, if they get the full dose, are in remission by the end of the day, which is just shocking. So profoundly grateful. And I know other people that I met in this study who had literally decades of treatment-resistant depression, and had gone through standard of care, every alternative therapy they could, and finally they were fortunate enough to receive the psilocybin as well, and instantly went into remission, and it's been enduring. Beyond 12 months. Yeah. So it's just amazing.
Yeah, I mean, despite how excited a lot of the people are in this space, I do still think that we need to do the research. We really need to, for the chronic pain patients specifically, it's like we need to figure out what to answer William's question, for our study, we're doing 25 milligrams. But we don't, we're in the infancy right now. We need to figure out what the appropriate dosage is, what the appropriate kind of like frequency is. Will it be able to be a one-time therapy? What type of physical modalities or cognitive therapy do we need to do to optimize the psychedelic neuromodulation? I think, and what we have good data about the safety profile, but are there specific cohorts of patients or sub-patient populations that don't respond, or it makes their pain worse? Right. So that's the last thing that that me as a researcher and a clinician want to do. My goal is to be able to answer the question of whether this is something that's going to help people, and as much hope as I have, and as much potential as I think it does have. If the clear answer is no, then then we move on to the next thing,
That's right.
because we got to figure out how to help as many people as we possibly can.
I think we're going to find that there's a pretty broad variety in who responds, what the dosage is. Like if we look at cluster headache population, they respond at a pretty low dose, right? We can even see like from the early the Kurumaru study, like they were responding to a relatively low dose. So I know we've got to wrap this up. Is there anything else in question for neuromodulation? So last question. Good afternoon. What about severe chronic bone pain from a 4-story balcony fall, which left me with compound fracture, tibia, broken hip, broken pelvis, broken sacrum, and wrist? 1998, high dose narcotics for 19 years, but now off all meds, right? So
yeah, I mean, I'm hopeful. I'm hopeful that that patients who have been suffering from chronic pain, the psychedelic neuromodulation can help at several of the levels that we think it does work. But like I said, I think we really still have to do the work. We really have to demonstrate objectively that there's signal there. And then once we demonstrate that there's signal there, we dive deeper and figure out how to optimize it through combination with different modalities or therapies, but also with different compounds. And I think that it's going to be a really interesting decade, and probably even further to see where things land.
And I think it bears repeating what you're saying right there is that it's not like taking an NSAID, right? Or Tylenol or even an opioid, right? This is something that is done in conjunction. You're not taking this passively. There seems to be a very interactive effect. The way I've described it is that psychedelics are an impact booster for neuroplasticity, right? And there's so many ways that we're trying to drive neuroplasticity through exercise, obviously through various types of neuromodulation, things of that nature. But I think people are going to be surprised to find that there may be some intervention that they're doing that sort of works, but doesn't quite stick around or doesn't quite get traction, like keeps the pain somewhat at bay, but not ever fully. And my contention is that psychedelics will be the thing that gets you across the finish line. And how frequently that needs to be done, unknown. Some people will be one and done. Some people will likely be doing it, for the duration, but not daily. Probably not daily.
No, definitely.
I think this is something that would be like once a quarter, or something of those lines. But it's different for different conditions. So I think it's a wide open field. But
I mean, I think it's going to turn into a whole new field of study, to be honest. I mean,
absolutely.
That's what I hope, at least I hope, because if that's the case, then it means that there's been significant signal and significant potential to help a lot of people.
I totally agree. That's why we put out our course, integrating neuromuscular rehabilitation with psychedelics. And it's like, it's as close to evidence-based as we can put together based on everything that's out there. So if people are interested, we do offer that for sale at remaptherapeutics.com. We have another interview on there with Dr. Castellanos, as well as many other people that came to our Psychedelics and Pain Symposium. Is there anything you want to say in closing that we haven't covered, or?
No, I mean, I think that especially if anyone who sees this knows patients suffering from, phantom limb pain, especially in the San Diego area, please do not hesitate to reach out via the QR code, or check out our website at phri.ucsd.edu. I can put that in the chat.
And we have that on
This
our
is a
Twitter
link.
account as well. Yeah, please do.
But yeah, great. Court, once again, thanks for having me. I think that I've said this before. I think you're really one of those people who is a pin in the space. You are well versed in everything that's going on, and I appreciate your passion and your willingness to have me on.
I can't thank you enough. And I've told you this before, but when your paper came out, like literally within 2.5 months of everything that happened for me, it was just it's hard not to believe into in fate or something happening on a higher transpersonal order. It's just your passion and your support has meant the world for me. So thank you for coming on here today.
Happy to be here.
All right. Okay, everybody. Thanks so much.
Thanks.
And we'll have this available online as soon as we can. Thank you all.
Yep.
I'm just going to do some screenshots of the comments. You can go if you want.
All right. See ya. We'll